Good afternoon, good morning, everyone. I want to welcome you to the CIDRAP webinar today. The title being Narrowing the Focus, Optimizing Antibiotic Spectrum Through Diagnostics and Stewardship. We're really pleased. This webinar has been a work in progress, and the CIDRAP, AMR, and ASP team has worked over the past 6 months putting together basically a white paper that features this topic. It's well-resourced and derives a lot of information from the literature. And we happen to have the experts on this webinar for you to walk you through some of the key data. And they're going to be presenting in this order. Dr. Tristan Timbrook, he has his PharmD, his MPH, MBA. He's an adjunct assistant professor, University of Utah College of Pharmacy, infectious diseases pharmacist at Barnes-Jewish Hospital. We have Dr. Chano Rhee. He has his MD, MPH. He's the director he's the director at the Center for Sepsis, Epidemiology, and Prevention Studies at Harvard Pilgrim Healthcare Institute. And finally, Dr. Jeffrey Gerber will be presenting his MD, his PhD. He's a professor of pediatrics and epidemiology, University of Pennsylvania School of Medicine. And I'll be your moderator today. I'm Dr. Marnie Peterson, and I'm the outreach coordinator at the Center for Infectious Disease Research and Policy. And we wanted to let everyone know, in case you didn't recognize that when you registered, that we are offering 1 hour of CE credit for pharmacists, physicians, and nurses. For listening to this webinar, it would just require that you take a post test. And we'd like to thank Roche Diagnostics for supporting this as an unrestricted educational grant. Elise, a few things just for me to cover before I hand it over to Dr. Timbrook. The objectives for the webinar today are to identify risk associated with inappropriate broad spectrum antibiotic prescribing, discuss the role of rapid diagnostics and the timely communication in guiding targeted antibiotic therapy, and apply evidence-based strategies for balancing prescribing, urgency, and stewardship. Different clinical scenarios will be presented. That's why we have these experts on with us today. And some disclosures. These are in accordance with the policy of our CE provider, MAD-ID, and the standards for integrity and independence. And this being a continuing education webinar. Dr. Tristan Timbrook was formerly an employee of bioMérieux, formerly. Is now in University of Utah, and myself am consultant at Centeron and on an advisory board for Grit Molecular Technologies. The others have no financial relationships with any ineligible companies to disclose, as well as the staff that reviewed the content. And with that is it. We're going to talk a little bit about claiming CE within 30 days, so you have till December 20th. MAD-ID and CIDRAP will send you the link of where you can go to claim your CE and take your test, and you will receive credits for this through CPE Monitor. 1 hour credit. All right, and with that, I think we're going to pause there, and I'm going to stop sharing the slides and let Dr. Timbrook bring his slides up.
Thanks, Mark.
And while he's doing that, the last thing I'm going to say is, for those of you coming on, is please engage with us. This is a Zoom format, so engage with us, sending questions to these speakers and experts today through the chat box or the Q&A box, and we're going to reserve about 10 minutes at the end for questions for these experts. So please send them our way, and we'll be monitoring this as your presenters provide information. All right, welcome, Dr. Timbrook.
Thanks. And can you hear me and see my slides?
Yes, can hear you and looks good.
Okay, perfect. Thanks for having me today. I'll be talking about sort of how diagnostics play a role in narrowing the focus. And so the title of my presentation is Fast and Accurate Isn't the Finish Line. It's really the starting gun. And so from data to de-escalation with diagnostics and stewardship. As Dr. Peterson noted, I previously worked at bioMérieux. Also, this presentation doesn't reflect the opinions of either of my affiliations. So to start, as far as the introduction, the urgent need to narrow the focus, just sort of to frame, this presentation and the rest of the presentations today quickly. As we all know, de-escalations should be important. However, there's a lot of data to support this, such as data that shows that early de-escalation of beta-lactams have been associated with decreased resistance hazards as far as development. Similarly, that's been shown with C. diff with very large hazard ratios. Whenever you delay that it increases the risk of C. diff. And as we know, about 1 in 5 patients on antibiotics experience an adverse effect while they're in hospital. So diagnostics can really serve as the accelerator to narrow focus. And so I'll start by talking about some general summations of the literature within diagnostics. The first one being a systematic review and meta-analysis of meningitis molecular diagnostics. This particular study looked at sample to answer molecular diagnostics using multiplex PCR versus standard of care testing in both the pediatrics and adults. And so they ended up having about 2,000 patients with either encephalitis or meningitis sort of presentations. And so this is associated with decreased healthcare utilization, such as the decrease in length of stay that you can see in the forest plot on the right, where it decreases about 1.2 days, which you can think sort of mechanistically correlates to the increased or decreased turnaround time. But again, sort of related to what we're focusing on today is that decrease in acyclovir duration, again, sort of correlating to that decreased turnaround time and really narrowing the focus of what therapies that we're giving to avoid toxicity, such as, AKI that can occur with acyclovir. And then finally, in pediatrics only, we ended up showing a 2-day decrease in antibiotic use. At least for me, I think that potentially that could be related to that the differential diagnosis is a little different in adults versus pediatrics. And so that and other sorts of differences in presentation could have drove that outcome difference. Shifting gears a little bit to summarize other rapid diagnostic literature. One of the up-and-comers that's been really hot in recent years that are commercially available rapid AST solutions. And so this is a summation of the literature related to predominantly accelerated pheno, again, having that rapid AST for bloodstream infections. And so as you can see on the very right of the table, most studies showed a decrease in some sort of healthcare measure as far as outcomes, including, as we talked about today, of narrowing therapy, again, being able to potentially decrease resistance, C. diff, other sorts of sequelae. Also, decreasing time to antibiotic change, time to optimal therapy. There's quite a bit of heterogeneity in these studies as far as how they operationalize that. But overall, whenever you have better information sooner, that can really drive outcomes, again, related to those risks that we talked about earlier. And particularly, I would feel remiss if I didn't notice that I think there's a lot of opportunity as we as a community really start to switch from molecular rapid diagnostics and bloodstream infections to rapid AST, particularly with the data in gram-negative uncomplicated bacteremia, where we can start to create bundles, say for PO switch, et cetera. And so really starting to think about, not just the diagnostic, but also sort of the effect change that stewardship has on the diagnostics as far as being the navigator of the information the diagnostic provides. Hopefully I don't lose some of you on this slide, but I'll try to walk through it. I just wanted to emphasize here that diagnostics are not drugs, right? The effects of diagnostics are indirect to the patient. And so that makes them more interesting, but more complicated. The effects are really mediated through your clinician. So you can see this in this figure here where the diagnostic provides the information to the clinician. Stewardship helps them modify that effect through education, prospective feedback, et cetera. And then they ultimately make a change in management. So again, very different from drugs where we have a direct exposure to the patient that drives outcomes. And so why is that important? Again, I wanted to go through a few different studies that gets into that you can't just drop a diagnostic in and have efficacy. And so the first one is from David Patterson's group about within the last 2 years, where they did a very large systematic review and network meta-analysis had about 100 studies, 10 RCTs. And so a couple of the key findings here: mortality was associated with about a 30% decrease with rapid diagnostics and stewardship compared to the reference alone. And so again, it really getting into that synergy, whereas if you just had RDT, as you can see in the forest plot on the right, it really didn't achieve statistical significance for decreases in mortality. Similarly, time to optimal therapy, as we talk about sort of narrowing the focus to improve outcomes, was significantly decreased, as was length of stay. Again, sort of the drive home here is it's that synergistic of rapid diagnostics with stewardship of that modification we saw in the last slide that helps to make these outcomes happen. But even to get further into sort of the granularity of that, stewardship is not a monolithic sort of implementation, right? Stewardship is very different and very different across hospitals. And so this is a study that I'm very proud of, where we looked within the VA and we were able to identify rapid diagnostics and bloodstream infections. We primarily focused on a change in spectrum score. And as you can see in the figure on the right, we did show that there was a decrease in the quasi-experimental study of pre versus post on spectrum score changes within time periods following positive culture. However, the really neat part is we used a survey that they routinely do for all the stewardship characteristics at the different centers. There's 130 of them in the VA. And so we were able to look at the characteristics that were associated with different diagnostic effectiveness. And so you can see stewardship review at days 1 and 2 were associated with significant improvements in de-escalation, automated ID consults, improved time to effective therapy and de-escalations, again, sort of that interaction with the rapid diagnostic. And then facilities without sepsis treatment pathways, there was seen an improvement in mortality. Shifting to respiratory, in recent years, the IDSA guidelines endorsed use of MRSA nasal PCR. As most of you know, if you aren't colonized with it, you're probably not going to be infected with it because you don't aspirate it from your upper airway. And so the IDSA approved that based off of performance data and very, very limited outcomes data. This is a snapshot of the outcomes data. And as you can see, again, as we had with the rapid AST, is with the MRSA nasal screens, there's a decrease in a lot of the things that you would hope to see, with decreases in vancomycin, which are often associated with decreases in AKI, also decreases in vancomycin trough monitoring and length of stay. But one of the key things that I'll note here is it seems to be, if you look at the bottom of the chart versus the top of the chart for the interventions, is that the ones that really achieved changes were with active stewardship interventions. So in summary, does this RDT improve outcomes as far as narrowing, therapy? Does it work? Well, again, it kind of depends on what you mean by does it and work. It really needs this stewardship and even sort of granularly different types of stewardship to make it work. And so I really hone with Kevin Mescar's classical figure that it's a synergistic relationship between stewardship and diagnostics. I would feel remiss if I didn't mention that there's been obviously a boom in artificial intelligence. And I think of artificial intelligence because it classifies and provides information as much like a diagnostic test, that it can be somewhat substitutable. And so this is a recent study where they trained on patient days and looked at a ton of features to see who was likely to be able to have an opportunity to discontinue to IVDPO switches, early de-escalations and late de-escalations. And so on the figure on the right, you can see if you have a ton of antibiotics on board, that's going to be the largest driver of being able to have de-escalations, right? And so sure enough, they were able to hone in on patients that they were able to have early de-escalations more than manual chart reviews. And so I think that, as we start to adopt these types of technologies, it can help us to be a lot more efficient in finding the signal and the noise. So in conclusion, I think about the sort of future of optimization. Again, fast and accurate isn't really the finish line, it's the starting gun. We have to take that information and translate it into actions, which often takes, experts like stewardship teams to help frontline clinicians in decision making. Again, as David Patterson's group showed, diagnostics alone and the data alone don't change outcomes. It's really that synergistic relationship, and we need that for de-escalations as well. So we really need to hardwire things like protocols, pathways, maybe even artificial intelligence to help us achieve those outcomes. And with that, I'll turn it back over. Thank you.
Excellent. Thank you for the nice overview. So Tristan was giving us the overview, and Dr. Reese now going to begin sharing his slides and come and talk a little bit more about his research as it pertains to sepsis management, balancing urgency and stewardship. Dr. Reese.
Okay, great. Thank you so much. It's a real pleasure to give this talk on balancing urgency and stewardship in sepsis. So I have a lot to cover in a short amount of time, so I'll jump in. These are my standard disclosures, but I have no financial conflicts related to this presentation. So I'm really glad we're talking about this topic. Sepsis and stewardship is very important. It's also very challenging. We know that appropriate antibiotic therapy saves lives in sepsis, but we also know that diagnostic uncertainty is common. Cultures take time to mature and are often negative, even in true bacterial sepsis. And there's a widespread perception that there's zero margin for error. And I think this fear of undertreatment is really what drives broader and longer therapy. And this is exacerbated by guidelines and regulatory pressure. The Surviving Sepsis campaign and SEP1 both emphasize time-sensitive goals for broad-spectrum antibiotics. So the question is, how can we improve stewardship in sepsis? Well, we just heard a lot about rapid diagnostics, so I'm going to focus on other aspects. But I think building on the theme from the last talk, there is no one single silver bullet. It's a complex problem, and really it takes a multi-pronged approach. So what I'm going to talk about is 7 key principles that I think really highlight opportunities across the continuum of sepsis care. So starting with the first one, I think we need to recognize how frequently we overtreat. And so there have been several studies looking at this topic. This is one that we recently published in the CID earlier this year. It was a retrospective chart review-based study of 600 patients with suspected sepsis who were treated with broad-spectrum antibiotics in the emergency department. And after detailed chart reviews by experienced clinicians taking into account all available clinical information after the fact, we determined that about 1 in 3 of those patients were unlikely to have had bacterial infection on presentation, meaning that they probably didn't need antibiotics at all. And among the 2/3 who did have bacterial infections, the antibiotics were too broad or broader than necessary in retrospect in about 4 out of 5 cases. So overall, 86% of patients were likely overtreated in retrospect. And this is contrasted with 8% who were undertreated with inadequate empiric regimens. We also looked at this using a big data approach. So that was a chart review-based approach. This was a big data approach using the PINK AI data set, almost 900,000 adults admitted with suspected community-onset sepsis to 241 hospitals between 2017 and 2021. Now, there's a couple lines on this graph. The main one I would highlight here is in red. This is the proportion each year that received empiric anti-MRSA or anti-pseudomonal antibiotics. And you can see it hovered between 60 to 70%, and it slowly but steadily increased over the time period. And then this top line is the fraction of patients who were treated with anti-MRSA and anti-pseudomonal antibiotics, but did not have a resistant gram-positive or resistant gram-negative organism identified in retrospect. So you can see that that was about 90% and also increased slowly over the time period. Okay, so we know that we are very frequently overtreating patients. I think the next thing I'd like to emphasize is the importance of recognizing the potential harm of antibiotics. If we don't think of them as potentially harmful, then we're going to not think of any downside to using them, right? And so Tristan has showed this study, but I'll highlight it again because it's a really important one, emphasizing that antibiotic-associated adverse events are common. This is a retrospective analysis of almost 1,500 patients admitted to general medical wards, and they found that 20% of them experienced at least one antibiotic-associated adverse drug event within 30 days. And most of those were, or the plurality were GI, but there were also renal side effects, hematological, and a slew of other types of side effects. And also, within 90 days, 6% developed a new multi-drug resistant organism, and 4% developed C. difficile. The other thing that's important to understand is that there really is a dose-dependent relationship, and even a few doses increase the risk of harm. And this is a study of veterans who underwent non-cardiac surgery and were receiving antibiotic prophylaxis. And you can see that with each additional day of antibiotics, the risk of acute kidney injury and C. difficile increased. So I really like this study, and sort of if you read the paper, their conclusions, I just sort of borrowed this quote, which I think is really nice to highlight. Every day and every dose matters. Building on that theme, there's a risk of antibiotic resistance that increases by each day of exposure. This was a retrospective analysis of over 7,000 patients with sepsis who received at least one anti-acetaminophen beta-lactam. And within the next 180 days, 6% of those patients developed new resistance to the anti-acetaminophen beta-lactam at a median of 17 days. And they were able to quantify that each additional day of exposure increased the risk of developing resistance by 4%. In addition to toxicities and resistance, there's also a link between unnecessarily broad antibiotics and mortality. This is a study we published a few years ago using the Cerner data set, over 17,000 patients hospitalized with culture-positive sepsis. And then we looked at patients who received inadequate empiric therapy, so therapy that wasn't active against the pathogen that was identified, but also looked at those who received antibiotics that were unnecessarily broad in retrospect. So again, they got MRSA or seminal coverage, but no resistant pathogen was isolated. And what we found was that, yes, inadequate empiric therapy was, of course, associated with the increase in the odds of death, consistent with many prior studies, but also unnecessarily broad therapy was similarly associated with the increase in the odds of mortality, as well as acute kidney injury and C. difficile. So again, emphasizing that both undertreatment and overtreatment are associated with worse outcomes. Okay, moving on from the harm of antibiotics, then we need to rapidly identify the patients that truly need immediate antibiotics versus those who can wait a little bit. Now, the dogma in sepsis has long been that every hour delay in antibiotics matters. This is an infographic from our friends at the Sepsis Alliance saying that the risk of death from sepsis increases by as much as 8% for every hour that treatment is delayed. And diving into this literature, this number comes from Anand Kumar's famous study in critical care medicine back in 2006, where that's exactly what they found in this analysis. But it's important to understand that this cohort was limited to patients who had septic shock. And so the question is, does this apply to sepsis without shock? This is a study from Chris Seymour and colleagues published in New England Journal of Medicine. They analyzed almost 50,000 patients treated in New York State under Roy's regulations for sepsis. And the top line finding was that each hour delay in bundle completion was associated with a 4% increase in the odds of death, which was driven primarily by delays in antibiotics. But importantly, when looking at subgroup analyses, that mortality signal was only seen in patients with septic shock, as marked by those who were requiring vasopressors, and there was no significant signal in patients who were not in shock. Numerous other studies have found similar findings. I'm sharing one from our group, published just 2 years ago, a very large study, over 100,000 patients admitted with suspected infection to our healthcare system. We modeled associations between hourly delays in antibiotics and risk-adjusted mortality. And what do we found? What do we find? Increased mortality risk seen with hourly delays in patients with septic shock, but only after 6 hours in patients with suspected sepsis who did not have shock. So again, there are many other studies that have come to similar conclusions. So what are the implications of this? Well, I would say that if infection is just one of several potential diagnoses and the patient is not in shock or critically ill, then in many cases, we can actually take some time to initiate a workup. And even a few short hours can often provide more diagnostic clarity and at least inform a more, you may still decide to give the antibiotics, but you can have a more thoughtful choice of empiric antibiotics. On the other hand, antibiotics should be given promptly if infection is clear-cut or probable, or if the patient is in shock with a possible infection, because we can all agree, and the data show that there's really no margin for errors in those patients. Okay, next, it's important to select, once you've decided to treat, to select your empiric antibiotics based on each patient's risk factors and the local epidemiology. So that is a really important question. How do we stratify patients who are at high or low risk for MDROs? And there's numerous scores out there and different guidelines. I like this set of guidelines from 2016, the IDSA ATS hospital-acquired pneumonia guidelines, because they sort of emphasize some of the key ones. Prior intravenous antibiotic use within the past 90 days, that's consistently an important risk factor. Also being hospitalized for at least 5 days. They also mentioned septic shock, ARDS, and being on acute renal replacement therapy. And of course, a big one is if you know that the patient has a prior history of being infected or colonized with a multi-drug resistant organism. But even without the history, I think it's important to know your own hospital and unit specific antibiogram. Here's just a snapshot from an antibiogram from our own hospital at the Brigham Women's Hospital. And obviously, there's a lot of variability across regions and hospitals and even within units. Now, I wanted to mention the INSPIRE trials. These are really important trials that were just published within the last 2 years. Four of them published within the JAMA network. And they really sort of crystallized the fact that risk-based prompts that incorporate patient factors, including their demographics and prior microbiology, as well as the local epidemiology, can safely reduce unnecessary broad-spectrum antibiotic use in a variety of infectious conditions, including pneumonia, UTIs, skin and soft tissue infections, and abdominal infections. Okay, next I want to emphasize the importance of obtaining adequate cultures prior to antibiotics. So this is one illustrative study where they did a prospective multi-center audit of antibiotic prescribing in France. And amongst over 400 patients who were on antibiotics, about 37% of them were deemed unnecessary. And that's pretty consistent with other literature. And on multivariable analysis, the main risk factors for being on unnecessary antibiotics were not having a clear diagnosis and relatedly, not having drawn blood cultures. And in terms of the importance of getting those blood cultures before antibiotics, this is an important study published in Annals of Internal Medicine a few years ago, where they tried to answer the question, what is the differential yield? What is the loss in yield of blood cultures if they're given shortly after antibiotics? And so they basically enrolled over 300 patients with septic shock, and they drew blood cultures before and then immediately after antibiotics within 2 hours. And you can see basically that the sensitivity of the blood cultures was reduced by about half. So even those short period delays in getting the blood cultures can be impactful. Okay, next is to de-escalate antibiotics as soon as feasible. And this could be a whole talk in of itself. But I think a really important question is antibiotic de-escalation safe? And this is a meta-analysis of multiple observational studies and randomized controlled trials, basically look at the clinical impact of de-escalation. The bottom line is they all very consistently do indicate that de-escalation, obviously when appropriately done, is indeed safe. This is a more recent large cohort study that our group published. We looked at over 120,000 patients with suspected sepsis who were treated with anti-MRSA and anti-pseudomonal antibiotics and who did not have resistant organisms identified at their hospital day 4 and thus were eligible for de-escalation. And first, we found that only a minority of these patients had antibiotics de-escalated. There was also a lot of variability across hospitals. We identified some predictors of de-escalation, but I think the key thing I want to highlight here is that after detailed propensity score matching, de-escalation was associated with a lower risk of adverse outcomes, including acute kidney injury, C. difficile, ICU admission, and even mortality. Tristan mentioned the nasal MRSA culture and PCR to help guide de-escalation, particularly when supported by antibiotic stewardship. And I'll just highlight this again because I think this is a really simple, intuitive tool that can be very helpful for de-escalating, vancomycin therapy. And this meta-analysis of 22 studies really highlights the key statistics here. So here we're not so interested in the positive predictive value, but really the negative predictive value, right? 98% is really good. And so really the answer there is yes, a negative MRSA swab can help you safely de-escalate vancomycin for suspected pneumonia. Okay, my last section, I know I'm running short on time. I think the other key piece is that we can shorten treatment duration by knowing the randomized controlled trials for specific infections. And over the past two decades, there have been numerous trials that have compared short versus long durations for various infections. Almost invariably, they show that the shorter duration is just as good. I'm going to highlight a couple quick hits here. This is the Stop It trial looking at complicated intra-abdominal infections, published in the New England Journal of Medicine. They compared a strategy that gave antibiotics until resolution of clinical signs, which in practice led to about 8 days of antibiotics versus a fixed short course of 4 days. And you can see across all the outcomes, surgical site infection, recurrent infections, death, or a composite, there was no difference. When it comes to pyelonephritis, looking at short 5 to 7 versus 10 to 14 days, this is a little bit of older meta-analysis, but still a relevant one. You can see no difference in clinical failure rates. When it comes to pneumonia, our treatment courses have gotten shorter and shorter. This is the 5 versus 10-day trial done in Spain. Basically no difference in clinical success rates, even amongst the patients who had severe pneumonia, as indicated by high port scores. And then even pushing the bar even further, the PTC trial published a few years ago, 3 versus 8 days for CAP, done in France. These are non-critically ill patients with community-acquired pneumonia. And you can see here also no difference in clinical cure rates with the 3 versus 8 days. And this is what's informed the most recent update to the ATS CAP guidelines, saying that for non-critically ill patients, 3 or 4 days of treatment is likely sufficient so long as the patient has achieved stability. And then lastly, the BALANCE trial, of course, a big trial that was just published in the New England Journal of Medicine, 7 versus 14 days for patients with bloodstream infections, showing there was no difference in the primary outcome of 90-day mortality, even in the subset of patients who were enrolled while they're in the ICU or on vasopressors or with very high Apache scores. So that is it. Here's my recap of the core principles to improve stewardship and sepsis. Again, recognize how frequently overtreat. It's very often. Recognize the potential harm of antibiotics. Rapidly identify those patients that really need immediate antibiotics, particularly septic shock. Selecting empiric antibiotics based on risk factors and epidemiology. Obtaining adequate cultures before antibiotics. De-escalating as soon as feasible. And then knowing the randomized controlled trials for specific infections. Thanks so much.
Excellent. Thank you so much. I see we have many participants there. So I hope they were paying attention and took in all that information. Please, if you have any questions, go ahead and submit them to the chat box. And I know Dr. Gerber is getting ready to now switch gears to pediatric antibiotic stewardship across different settings. Dr. Gerber, when you're ready.
Okay, can you hear me and see the slides?
Yes.
Terrific. Well, thanks, John. That was terrific. Thanks, Tristan. Two great talks. I'll do my best to finish things up here on time. So as background, I've got grant funding, CDC, NIH, PCORI, HRQ, and then have done some vaccine trials, but no pertinent conflicts of interest. I've had some travel money to present for AAP and for the Pew Charitable Trusts in the past. So overview, I'm going to quickly talk about an approach that we take to pick targets for stewardship. And then I'm going to be kind of all over the place, but mostly focusing on outpatient stewardship because we do a fair amount of that, but then talk about a few novel targets, looking at hospitalization and at the point of discharge, some critical care stewardship, and some focus on duration, and then a couple of parting thoughts if I have time to get to it. So picking targets for stewardship, what's the best thing to do? Really, it should be data-driven, and then this combination between conditions where there's high prevalence and high variability, or at least variance from guidelines or evidence if it's not variable, if it's just wrong. So one thing we did a while back, more than a decade ago, we used the FIS, Pediatric Health Information System, has more than 40 freestanding children's hospitals, and said, what are the conditions that account for the most antibiotics per hospital day in children? And it was these 4: pneumonia, cystic fibrosis exacerbation, appendectomy, and skin and soft tissue infection. And we plotted the days of therapy versus the proportion overall receiving therapy by hospital. The circles are the size of the hospital. And we looked at first-line therapy for pneumonia, MRSA therapy for cystic fibrosis, for skin and soft tissue infections, and anti-pseudomonal therapy for appendectomy, and said, okay, we have a lot of variability here. Let's stay away from skin soft tissue infections because there was less variability, and did a couple of non-comparative effectiveness studies for pneumonia and for appendectomy, showing, not surprisingly, that narrower spectrum agents are fine. And we've actually just delved into cystic fibrosis. So we think this is a fruitful approach both in inpatient and outpatient settings. But if you want to address stewardship in any setting, certainly in pediatrics, but adults as well, you have to be in an outpatient setting at some point. More than 90% of antibiotics are used for outpatients. In pediatrics, kids don't get as many chronic diseases as adults, so a lot of it are acute infections. And so you can see here, looking at the top 6 most commonly used drugs in pediatrics, systemic antibiotics blows everything else away. So we need to focus here in the outpatient setting. And then when you're in the outpatient setting, it's really acute respiratory tract infections. 1 in 5 kids who walk into a pediatrician's office leave with an antibiotic. And that's the denominator of every visit, whether it's a sprained ankle, headache, or a well check. And almost 3/4 of those are for acute respiratory tract infections. So So we focus there. And when you look at targets for stewardship, whether it's outpatient or inpatient, there's a bunch of different domains, right? So you can look at, should they get them at all? If they get them, what should be the choice? What should be the duration of therapy? And you can even get into dose and timing. I won't get into timing, trying to cover that very, very well. So first, choice or spectrum of activity. We looked, I'm going to show you a couple of slides looking at the Children's Hospital Philadelphia healthcare network. We have 32 practices. These are 25 of those practices. And this looks at kids who attend the practice. If they get an antibiotic, how often is it broad spectrum? This is adjusted for age, sex, race, insurance type, antibiotic allergy, medical complexity. So it's really the same kid going to a different practice. And we saw that if you go to one of these practices on the left, you have about a 15% chance. One of these on the right, more than half the time you're going to get a broad spectrum antibiotic. So with these partners, we did something called the series study, where we very simply compared broad spectrum versus narrow spectrum antibiotics for common acute respiratory tract infections. Working with Julie Simzak, partnering with Julie shown in the upper right. She's a medical sociologist who's just a terrific expert in antibiotic stewardship. She helped us derive the outcomes, and we work with our parent partners. She interviewed families and patients and families in waiting rooms and found that not just treatment failure, but things like missed school and work, sleep, side effects, and how quickly that got better mattered. So we then did this comparative effectiveness study. We called almost 2,500 kids with these common respiratory tract infections after they left the pediatrician's office day 5 and day 10 to 14, and found that from our primary outcome, there was no difference in quality of life at 10 to 14 days, and there was no difference in all these other outcomes that Julie helped us identify: missing school, daycare, additional childcare, and sleep disturbance. However, kids who got broad spectrum antibiotics were significantly more likely to experience adverse effects. So how do we implement this? I'll summarize this in a couple of slides. This is a picture of one of our primary care practices. We have 32 in the network, and we do a lot of work in this practice-based research network. And I'll highlight what Julie and others have said. Antibiotic prescribing, we think of it as a medical and a scientific act, but it's really a human behavioral act. So we have to think about the levers we can push around human behavior. And so we have, and others have, focused on auditing and giving feedback to providers to show them how they're doing, to show some competition among their peers. And this is just an example of a 12-month study we did a long time ago, looking at assessing baseline data and then giving 3 feedback reports over 12-month time. And you can see in the upper right, this is what these reports look like. And we compared them to standard guidelines. And then we compared folks how they prescribe broad spectrum antibiotics in this case to those in their practice and those in the network. And we found that we could reduce antibiotic prescribing just by showing them with a little bit of education and with this audit and feedback. And I won't show you all the data, but I'll just summarize a few things that we've really focused on. When you're trying to improve prescribing, you need to explain to people the why and get them engaged, right? So they aren't always just going to be motivated by getting a feedback report, or who's this sending me this, from the ivory tower sending me this in my busy practice. So you want to make sure the rationale is clear, that it's linked to best practices to optimize clinical outcomes, not really talking about public health and antibiotic resistance, but talking about clinical outcomes. They will get better as faster with narrow spectrum agents, and they will have fewer side effects. So those really tend to resonate. Make sure that you get input from those that you are giving feedback to, that you're trying to improve prescribing around. We often have clinical champions in a lot of our studies who are actual prescribers who buy into this and will help educate and proselytize what we're selling to the rest of their group. And everybody wants to do the right thing. This is not a bunch of people trying, not caring or not practicing right on purpose, right? They have a lot to do, a lot on their plate. They might not know the updated guidelines. Help them. We want to make sure that they believe the data that we have behind the guidelines, and then the feedback report data from the beginning. Sometimes they don't believe it. So make sure that they help you construct those feedback reports, take a peek behind the curtain, give you input on what's right and what's wrong, show them how you validate. And then over time, even we sometimes give them links where they can They can self-audit reports that they might get to make sure every patient that we said might not have been on guideline is true, and that's a really important way to get buy-in. Okay, so now that was choice, talking about yes or no. The best way to improve stewardship is not to give antibiotics at all, and this, there are lots of opportunities in the outpatient setting for sure. Here, the same 25 practices, before I was showing you prescribing antibiotics for broad spectrum antibiotics, this is diagnosis. So these are the bread and butter diagnoses in pediatrics. Acute otitis media on the left, you can see a more than twofold variance in the rate of diagnosis of acute otitis media per sick visit, again, standardizing for all these potential confounders. That shouldn't happen. For sinusitis, there's tenfold variance across practices in the rate of diagnosis. And for strep throat, something for which we have a very sensitive and specific diagnostic test for, we see more than twofold or threefold variation across practices. So this is a problem. But how do you get people to, how do you audit and do epi studies and interventions to audit and assess and then reduce prescribing for viral infections? Nobody's going to code for a viral infection and give an antibiotic, right? The codes are kind of used fast and loose. People sometimes upcode. If they think maybe it's sinusitis, it could be a virus, they'll call it sinusitis. So we and some others have tried to create a metric that we're just testing out now, where instead of looking at you're prescribing for otitis media or prescribing for viral infection, NOS, or flu, which most people don't do, we have a composite outcome. The denominator is all encounters for acute respiratory tract infections, bacterial, otitis media, strep throat, sinusitis, or non-bacterial, bronchitis, URI, bronchiolitis, flu, non-streptococcal pharyngitis. And we look at the proportion of all those diagnoses for which an antibiotic is prescribed. And the premise is that, or the assumptions are that if the sample size is large enough and you do it for all seasons, you should and these people and the sample size is big enough, it should be pretty consistent across practices given similar triage. And we recognize that could be a difference if one practice lets in less sick patients than others. And we've looked at this. This is across 50 practices across the country, more than 2.5 million encounters. And you can see the diagnoses on the left. But when you put these together, the rate of prescribing for all ARTIs varies from around 25% to well over 50%. And so we've now started to feed back this metric to prescribers, and hopefully we'll find some good outcomes. All right, so this is Marcus Freeman, my favorite coach in all sports, and one of his lines is to challenge everything, and that's something we really need to do in stewardship. And so looking at frequency, so yes or no, this is a study we just kicked off. The multi-PRs are Todd Florin and Julie Simzak in the upper right. Katie Shodas is seen below. Katie and I are the site PIs for the CHOP parts, and this is the STAMP trial, and this is looking at safety net prescribing to manage outpatient pneumonia. And so it's super common that kids get diagnosed with pneumonia in the ambulatory setting, but most pneumonia, it's true in adults too, but most pneumonia kids, especially those under 5, is viral, but most get antibiotics despite epi studies showing that you get better either way, whether you get them or not. So this trial, and we just kicked it off, it's going to be a 5-year PCORI funded study, is looking at immediate antibiotics versus watchful waiting, safety net prescribing for kids with outpatient pneumonia. And it's very similar to watchful waiting for or safety net prescribing for otitis media. And our hope here is this is the first step toward reducing prescribing for a condition that is largely viral. Duration of therapy, quick slide about a study that we just completed, and we're in the process of the data analysis, the DISCO trial. And this is looking at kids with community-acquired pneumonia, urinary tract infections, and skin soft tissue infections who are hospitalized, non-critically ill who are hospitalized. And we look at the prescribing at the point of hospital discharge. Many kids go home on 10 to 14 days. We have evidence that 5 to 7 days is the most that we need. And we have given feedback, again, audit feedback at the group level, instead of individual level here, group level feedback to our hospital medicine folks. And you can see here, the blue plot is the antibiotic choice being appropriate. The orange plot is duration of therapy. That's really where we had room to move. And you can see over time, we've really improved. And on the right, we've done some competition across centers. This is a 4-center trial, CHOP, WashU, Seattle, and Utah Primary Children's Hospital. So hopefully you'll see some data published there. And I'll end with just, again, trying to, try to challenge everything. And even in the most complex cases, a lot of my stewardship work is in the outpatient setting, some is in the inpatient setting, but my clinical work is in the inpatient setting on our immune compromised service. And we see lots of really critically ill kids who, as patients on ECMO, and we want to make sure that we can steward these patients as well. And Shano just gave a terrific overview of his, primarily his work, but many others' work as well on how to, stewarding critically ill adults. Katie showed us, who is also ID and critical care trained, did some terrific work at Children's Hospital Philadelphia, looking at a couple years of PICU admissions, where there were more than 1,200 kids who were ruled out with broad spectrum antibiotics for sepsis, and found that when you separate those who were in septic shock or had specific conditions where we knew the issue, all these kids were getting vancomycin empirically. Vancomycin is cefepime or vancomycin, and only 6 were positive for MSA from the bloodstream. 4 had a MRSA history. So she found that of these kids, it's more than 10,000 doses of vancomycin for just a 48-hour rule out to take care of 2 kids who had bloodstream infections with MRSA. And she conducted a terrific PICU-centered quality improvement project showing a dramatic reduction in vancomycin days of therapy with no detriment in patient outcomes. So no missed cases of MRSA bacteremia and no changes in cardiovascular, respiratory, or renal organ dysfunction or mortality in kids despite this reduction. And she's now just completing a study called Revamp, funded by CDC epicenters, to expand this that expanded this to multiple centers. One last piece here I'll show you. Katie also has done some diagnostic stewardship, and she did some qualitative work with her PICU colleagues, and this is a quote from attending: "If there's a fever, culture everything. This is what happens. You culture it in a T-tube or a trach, and you get Pseudomonas, and what the heck do you do with it?" Katie did some education, audit feedback, and really it's to get at this. This is a bench, the respiratory bench in our infectious diseases diagnostic lab, working up a patient with one respiratory culture. They have to subculture so many things, and we don't know the difference between colonization and infection. So Katie did another quality improvement project where she showed that you could decrease the rate of ventilator associated cultures with no change in hospital length of stay, PICU length of stay, readmission rates, PICU readmission rates, actual ventilator associated pneumonia or mortality. Lastly, we've got, just so people know, in pediatrics, there's this thing called the Red Book, produced by the Committee on Infectious Diseases. This is Ritu Banerjee from Vanderbilt. Ritu and I helped create some fairly new system-based treatment tables. We know in pediatrics there's not as much evidence, but we've now got tables and tables of antibiotic choice and duration of therapy. We hope that you use these to prescribe, but also use these for generating more evidence. And we've incorporated the most recent 7 days for bloodstream infections, which we hope people will incorporate into their practice. So please look to that resource. So I'll end here, and I think this is really pertinent to the Chanu's talk for sure. Do good science. He and his group does such good science. We need more and more discovery. Use your EHR data wisely. Make sure you validate that like they do. Especially with administrative data, we have tons and tons of data, but we need to use it properly and make sure we're validating it and doing it the right way. And there's lots of terrific, partner with experts in causal inference, comparative effectiveness. There's terrific approaches to study design. It takes a lot of rigor, it takes a lot of validation, but there are ways to, find the truth or get really close to the truth without having to do an RCT. And I'm just going to end on the truth. This is a terrific quote from Emily Dickinson. We are in science is about truth. We are about finding the truth and then implementing the truth. And I'm going to go way off on a tangent, but just call out how terrific our CDC colleagues have been. The place is under attack. Just this morning, I saw that they changed their page on their immunization website to suggest that there is not evidence that that vaccines don't cause autism. We need to push back. We need to trust CDC. It's not the CDC that's really behind this. It's a small group of individuals. So continue to do science, continue to push the truth, and we'll get there. So I'll stop there and happy to take any questions.
Thank you, Dr. Gerber. I'm going to invite our speakers back. Can't believe you guys did that in less than 15 minutes. It's amazing. So much content there, and I think we've got some questions coming in. I'm going to kick it off with the data are there and the science are there to support a lot of the choices related to narrow spectrum de-escalating, and that rapid diagnostics, the impact though cannot exist without stewardship. So what I want to ask first is with Dr. Ree around in sepsis with someone that is not hasn't progressed to shocks. You showed that you have about 6 hours potentially to make this decision. So if you're from the perspective of a clinician, just wondering, my question lies in thinking about the action item here. You're trying to understand your antibiogram to prescribe the antibiotic. Narrow spectrum based on your antibiogram with the option to de-escalate. And is there a need with the rapid diagnostics that you're trying to get information in within that 6 hour window? So I'm just kind of wondering about the process and the thought process.
Sure, yeah,
and
I think it's
the
it's a good
opportunity.
question. If I can sort of rephrase that or say it again, I think it's a logical question. So, okay, fine. Maybe we don't have to give this patient antibiotics within 1 hour, but now we have 3 hours or 6 hours. And how much can you actually accomplish? How much of a difference does that make? Your cultural results are not going to get back. Even a lot of these rapid diagnostics, things like, the ones that are still culture dependent, like you still need the culture to grow. And so you're not going to get that information back there. And I think that's a very reasonable question. That being said, I do think, you can get more information within those first couple of hours. First of all, there are some rapid tests that can come back quickly. So for example, a lot of the PCRs around respiratory viral assays, will come back within 2 hours. And, that can certainly guide your decision there. There can be imaging tests, right? CAT scans or whatever to sort of better identify whether there truly is a source of infection. A few hours is often enough to see how the patient is responding to other therapies, whether it's fluids or maybe for a patient who has, heart failure and respiratory symptoms, if they're responding to diuresis. And again, I grant you still, I think with the current issue that I mentioned around this sort of zero margin mentality, I grant you that still a lot of clinicians, even if they feel like they're getting better or they haven't identified a source, they still want to give antibiotics just in case. And I think that's something we need to really try to educate staff on that a lot of times that is not the right decision. And the other thing I'll say is that even if it's been a couple hours there, it can guide a more thoughtful choice of antibiotics. So it is a difference between saying hey, ED physician, you have to give antibiotics within 1 hour. They're going to reach for their vancomycin or their vancomycin. They're not going to have time to look through the patient's chart or maybe call the antibiotic stewardship page or call the ID consultant to get a more informed choice of antibiotics. But if you give them 3 or 6 hours, then a lot of times you will be able to avoid those unnecessarily broad antibiotics.
And I was going to ask Tristan to follow on that. I mean, I just think it's an important point. And in even thinking of the post-test questions, like when you have this window of time, what can you accomplish? Because as your data has shown, you've got over-prescribing happening, adverse events that are happening. And if you're not de-escalating, you should be de-escalating. Tristan, do you think, with the rapid diagnostics test, we are where we are now? Can we get to the point where you're starting to have those tools with the stewardship so you can make the more and more informed decisions you can make within that first 3 hours, first 6 hours?
I think so. It obviously depends on the presentation, depends on the patient population. Patients that have significant comorbidities that are severely immunocompromised have very large differentials. And so a lot of those multiplex rapid tests hit, 80% of the common etiologies, right? And so in these more immunocompromised types of patients, that might not be appropriate. But I really think a lot about what Dr. Ray talked about with, really focusing on the most severe patients where you have patients that are in septic shock. And so, those patients, I think the diagnostics can help us get on effective therapy, but, you don't have a lot of margin for error, right? And so for de-escalations in patients that aren't clinically stable, a lot of times, it's just, you're not at 100%. And so I don't think, within the first 3 hours, we're really going to move the needle a lot with rapid diagnostics as far as de-escalations in patients that are severely ill. But I would say for the vast majority of patients that, yes, we can move, towards better therapies at the beginning up front within those 3 hours with rapid diagnostics.
Yeah, you're right. First determining what's the severity, the status of the clinical status of the patient. And then from there.
And if I could add just one more thing to that, I think, even the data I showed you was around sepsis, septic shock and sepsis, patients that had organ dysfunction. But there are other studies showing that patients that are not even septic or just sort of infected, much longer delays in antibiotics are not harmful, even on the order of a day or longer. And I think the problem is that sort of, at least certainly what I've seen in the places I practice, this mentality of every hour counts, that's been extended not from septic shock, but to sepsis, but then also to anyone with a possible infection. So any patient with a fever, overnight the team will start, vanc and cefepime just because they're worried. And I think really we've seen sort of a permeation of that zero margin mentality. That's really a problem.
Yeah. So understanding this data, and then the CIDRAP team's put a link to the report. So this has all been expanded in written format as well, this content. Dr. Gerber, I want to ask you a question to switch to the pediatric in your presentation around, if I got this correctly, a lot of the overprescribing of the antibiotics, when you looked at the acute respiratory tract infections, viral stood out as a category. I believe was one of the higher ones where they actually had viral infection, but were prescribed antibiotics.
Yeah, the problem is it is hard from the EHR or even from if you look at charts to identify that, right? Because people are going to make a diagnosis of sinusitis, which is often viral, or, one person's URI is another person's otitis media. So it's really tough. And that's why we use that composite definition to say, okay, if every kid who comes in coughing, sneezing, fever, whatever it is, what proportion of those get an antibiotic, almost agnostic of the underlying diagnoses, because it's really fluid. So otherwise it's really hard to identify those. And I think rapid diagnostics have their place in many situations. I'm a little bit of a pessimist about viral rapid diagnostics in those settings, just because essentially the pathophysiology of most bacterial infections is you start with a viral infection and then it's bacterial. And so I think a positive or a negative doesn't so much help you. So I think you just have to push people toward judicious diagnosis. Like sinusitis is when you have fever and your face hurts. It's not when you have a runny nose for 10 days. Like that would be every kid on earth has a runny nose for 10 days for like 4 months over the winter. So I think those are kind of some of the indirect ways we can get at that.
And then a follow-on, I'm looking at some of the questions that have been sent in. A follow-on to that, as you were speaking, and you did describe it. There's a lot of definition around what's a narrow spectrum versus what's broad spectrum. And I think helping people understand there's a narrow spectrum option and when they can use those. There is a question here around for rural community hospitals without access to some of these more rapid diagnostics. What other approaches have you seen work that can help reduce the dependence on broad spectrum antibiotics? And then the other question I have for you, Dr. Gerber, is around your audit and feedback, how frequently you provide feedback. So something around.
I'll start with that. Yeah, so we do anything from monthly to quarterly for audit and feedback. I would say, and then I'll let the others are experts in diagnostics, but the blood culture is still a good diagnostic. The regular old blood culture, they usually are positive within 12 or 15 hours. And so I think the rapid diagnostics are great, but I think you can still rely on that. And to related to that, and I think what Chanu or Tristan were talking about before, which I think Chanu was talking about this point of context with, you sometimes even a day later, there was a great study I'm sure you've all seen more than a decade ago. I forget which hospital in Virginia, where in the surgical ICU, as long as the patients didn't have, septic shock, anyone with a fever and a line, they ruled them out and they only they did a quasi-experimental study. Before it was culture, empiric antibiotics. After it was just culture and only give antibiotics if the culture was positive. And those patients actually did better. So like there are, blood cultures are still pretty good. Septic shock, again, throw the book at them. But if a patient has a fever or looks a little funny, you can send cultures and wait. I mean, so in that case, it doesn't matter what spectrum you use.
Jeff, I had that slide in my deck initially, but I had to cut it
Yeah.
out.